say something else.
Oh, yeah. Well, good morning and welcome to the Education Commissioning and Quality Committee. It's the last committee of this year. And it is
Progress.
and it is an open. We've got a bit of thank you. It is an open board, so welcome for joining online. We okay? Apologies for checking sound. Right, we'll start.
Getting some feedback. I think someone in the room might have their mic on, or
Check the keyboard with the mic here.
I'm just going to pause recording while we fix this.
Thank you. Thank you. Hopefully we've sorted the sound issues now. So welcome to the Education Commission and Quality Committee. And I have said that this is the final committee of this year, so welcome. There are also new members, and Jane is Sagro. Jane is a new member of the board who's joining us online, so welcome, Jane. Okay.
Thank you, Tina. I'm just chair as an observer.
Yes, thank you. And welcome to everybody else that's joining online. I've got a couple of other people that I want to welcome as committee members, and firstly to Donna MacArthur, who's been a board member now for about 6 months, and who is vice chair of this committee and will be taking over chair of the committee in the 1st of February next year. So welcome, Donna. Anton, well, you've joined the committee a few times in the past, so welcome again. And who's now Director of Education Improvement and Government, and Craig, Assistant Director of, I can't see Craig, Assistant Director of Digital, and who's joining via Zoom, and Nick, who's Head of Optometry. Yes, so welcome.
Clarify a couple of things.
Yeah.
So Anton is now the interim postgraduate dean, who is a standing member of this committee.
Okay.
Tom was the postgraduate dean, he's now deputy medical director. So the question is, do we need to add Tom's role to the list of people who attend this meeting?
I would think so, yes. From the perspective of the input and where we're talking about quality, so yeah. And I've seen Tom at a number of meetings as well, to welcome again, Tom. Anybody else that we've failed to mention? Yes, no? Okay. Apologies for absence. John Gammon, independent member, has given his apologies, and I understand Lisa Rowan is at another meeting and will be joining us late. She's presenting in Cardiff somewhere, so hopefully she'll be here by about 10:30. Okay. So going back to the full agenda now, are there any declarations of interest that are not already recorded and are pertinent to items on the agenda? No, thank you. Right, so we move then to item 1.4, draft minutes of the Education Commissioning Quality Committee held on the 14th of September. And we'll go through accuracy. And before I move on to that, I just want to say that Ruth, who is currently vice chair of the board, actually chaired that meeting. So Ruth, if there are any corrections, feel free to say.
Thank you, Chair. I just wondered, you're going to come to the minutes now, but I was wondering on the first page. Then I can pronounce it by my name and sort of explanation at the bottom of the minutes, because on the front, I know it wasn't that word later, isn't it? I just wondered on the list whether it might just then be the explanation later or something. Because as you just look at it, it looks a bit odd to have.
Okay.
Being chair and first chair.
Somehow, okay. So if we add the comments, acting
this
chair
meeting
for
only.
this particular meeting only.
Yeah.
Which was similar to what happened in audit committee when the vice chair, so then people were on that, so we can do that.
But it does explain it later, but if this is when you see the next one is going on here.
Yeah. Okay, so in terms of clarification then, we're going through the minutes for accuracy first, page 1. Page 2. Page 3. Page 4. 5. 6. 7. And 8. So are we content to approve the record of the minutes of that? Yeah. Okay, thank you. And if we can now go to the action log, which is item 1.5. And there are a number of items on the action log which are reported to be on the agenda. But from the action log, Wish, is there anything you wanted to update, or Martin, you standing in for Lisa at the moment, is there anything in relation to the action log you wanted to update, it's not already on the agenda?
No, so it's all on the agenda, and when it's still in progress, I'm on top of that.
Yeah, so 212 format and context of quality assurance update to be reviewed and updated. So I think we have put a fair amount of effort into the medical report to try and change the way it's presented and provide additional assurance to the board, the committee. But the just to comment that pharmacy, dental, and optometry very much smaller areas, and you, whilst the detail may not, there may not be the detail that you might have wanted, but actually there's much less activity going on in those areas. So I think the reports do reflect what's going on there. Just to say that in that context, there are comments that that's where we've got to.
Okay, Jill, you wanted to say?
I just thought it would be useful time to say it, that I found it particularly helpful. The separate, even though I understand the balance and the difference between the, I found it really helpful. And I think it's a journey, isn't it, that we're on? You know, we started with 15.1, we moved to sorry, started with them separate, so there was very little to say. Moved to, it was dominated then by the medical, and then I found this particularly helpful, and I think as time goes on.
And that's fine, and I think that's good. We were due to meet at execs next week to have a further discussion on how we provide assurance to this committee, but both Lisa and I are away, so it's going to be delayed until the week after. So I can say it's a journey, and we are trying our best to give you the information that will provide assurance to this.
I think that's an important point. Thank you, Jill, for raising that, because when we started the committee, the areas that had quite an in-depth review of quality was the medical workforce, and as a consequence, I remember you giving at the board development day, Anton, progress report and how we could adapt that to all of the professions, so there was some equity and equality between the reporting mechanisms. So we then adopted from the committee, bringing everything into one, and then there were some issues where there was change to the pharmacy development programme, which again needed a deep dive from a quality perspective, because if you're having a new programme, you do want to make sure that and get the assurance from a board perspective that's being developed. And also, Kirsty, in relation to the dental agenda, we were becoming more responsible for across the professional group of different professions that deliver their typically, and that's why we wanted that as well. So we reflected back, and I think the whole point of this committee in terms of getting the assurance is important to reflect and see how things are progressing. So I think it's perfectly reasonable to have this conversation and to say how we're going to move forward. And I think for the new chair taking over, good that you're listening to this from a perspective of how we might progress it in the future. So thank you for the input, because it is important to make sure that we keep this record and celebrate the good news from equality, and also make sure you've got sufficient resources to deliver where there are challenges. Yes, so, and we only get that from a full report of the policy agenda, don't we? So thank you. Okay, so is there any other comments in relation to the action log? Okay, so if we're going back to the minutes then, any matters arising that aren't already on the agenda, and I'll open that up for any matters arising. I won't go through the pages, just ask if anybody wants to raise anything. No. Okay, thank you. Right, so having completed part 1, we're now moving to part 2, 2.1 more professional education training quality assurance updates, and over to you, Bush.
So as I said earlier, that this is the newer format that we are trying to utilize in reporting activity within the medical deanery. I'm going to hand over to Tom and Anton shortly to go through the details, but I think that in a way, this is the long version, and it may be that we have to go to a section reporting in the future to make it clear, but once in a year, perhaps we do need to do a long version so people understand how we apply the quality management process to medicine. The other thing is always worth repeating is that all of this work is directly responsible to GMC's requirements of medical training here in Wales. So a lot of the decisions that are made are, well, all the decisions that are made about the status of some of our sites where there's difficulties are agreed and endorsed. Well, they're implemented by GMC on our recommendations, and as up to now, we've never had a recommendation not be taken up, or a recommendation or that's not in line with what we've recommended from the GMC. So don't know if Anton or Tom wanted to say anything further on this paper, because I'm assuming that you've read it.
Thank you, Bush. There's an awful lot of detail behind the paper. We're trying to summarize what we think is important for you as a committee and a board to know and to be reassured about the work that we're doing. I don't know if you want me to talk you through the headings of the paper. I'm sure everybody's read it, or whether you just want to go straight to questions.
We have read the paper, I take it that all members have. How does the board feel? Do you want Anton to give an overview of each section, or straight to questions? Okay, just before you do that, Anton, in relation to the report that you've given, would there be any areas that you would recommend that we should actually hear from you?
Indeed, I do. I think we should talk around recruitment.
Okay.
I can give a very brief summary of the trainee survey and the trainer survey. I think that we can mention the areas which we're looking at a little bit more closely. I think that's where I would focus my attention on at the moment. Okay,
so if people are happy, if we have that first, and then we go questions, because there may be questions that arise out of your presentation or what may answer some of that. So I'm pleased about that, because that's an area that I wanted you to develop. So that's speaking to you beforehand. But okay, so over to you then.
So this, and as you can see from the, and I've lost my place immediately. And as you can see from the report, we have tried to structure it more succinctly. We've aimed to couple the work that we're doing to our duty of quality requirements, and we've also it's still implicit that it's in a format that reflects planning quality, managing quality, assuring quality. It's just to make it flow. We've restructured the reports slightly differently. So we've presented some data on the recruitment. I am pleased to say that training posts in general practice full for August, and recruitment to post the secondary test has gone well. A little bit better in core than in higher, but this is not unusual at all. We had, so very pleased with that. You will remember that posts in the foundation training program has been expanding. And despite initially filling all posts, we've ended up through a sort of a natural process which happens in every country and it happens every year, to having some unfilled posts. We have mitigating action in place for that. That's mitigation actions both locally, but also across the UK, because of course we get late withdrawals and we get folks who don't quite make it through the exams, etc. So we're still working on that. But according to the things that we should do in terms of safe and timely, I think we're quite pleased with our recruitment. I will leave that there unless there are any specific questions about. We will report on this periodically. I'm not 100% sure about the timings yet. We'll, as recruitment gets done, I think it will come in different timings for this committee of the board, but we'll put it in when we have those numbers.
Okay, thank you. And so I've got questions, Jill, and then Ruth.
Yeah, do you want to take questions? Are you okay to take questions as you go along?
I think so.
Yeah. Okay, so in terms of recruitment, it's pleasing that we obviously have had a good response. The foundation bits, there's a lot of vacancies, aren't there? 61 compared to last year. Is there anything that we would or could do differently now that we've had a couple of years of quite a big vacancy rates? Is there anything that, a real change in the way we approach this?
So recruitment is national.
Yes. Yes.
So that is
Yeah.
the first point. However, I think there are things that we can do, and the things that we're doing now. A preference-based system may be helpful. And I'm lucky to have the co-chair, lucky to have Tom here as well, who knows this inside out. I think that so recruitment is a national process, but people will be able to preference Wales. If they preference Wales, then they would be able to get into train here. And we know that people who come and train here, even are more likely to stay here. Also, I think there are some things that we've started to do that we can do more of. I mean, we have started a recent pilot on extended induction. There has been some incentives, for example, for accommodations. I think it's something that we still have to think about. But I think there will it's likely to be more of a challenge going forward. I'm sure we can do some things in the same.
Shall I add to that? So yes, I mean the context, I think the numbers look daunting, but that's partly reflective of our ambition to increase to where we are. So the vacancy numbers look greater. The actual head count of doctors we've got brought into foundation this year is exactly the same as it was last year. And that partly suggests we're sort of hitting that UK-wide capacity at the moment. And I think it's understanding where those things. So we were full at foundation at the point of starting. This is attrition, and that's partly from finals failure, which is a relatively stable entity in the UK. The unpredictable thing that we don't have control on is international medical graduate applicants, and approximately almost 30% of those withdrew across the UK. So this picture is mirrored elsewhere. It's not a reflection of what we're doing. And this year's been hit a little bit harder in terms of attrition because of our proximity to the Republic of Ireland, which is the problem we're trying to address. And for the members of the committee to understand that, the Republic of Ireland have a slightly strange system whereby they graduate far more students than they have foundation post numbers. And therefore almost every student applying from Republic of Ireland throws an application in to the UK foundation programme. But then when they get offered their post in the Republic of Ireland, they withdraw very late in the process. We were hit quite hard, so over 30 of our withdrawals this year were from that. There's been a lot of discussion at the UK level trying to address this, and there is progress, and we're seeing a drop of 2/3 of the number of the Republic of Ireland applicants this year in the foundation programme across the UK. And we're seeing about 1,000 increase in UK graduates applying to the UK programme this year. So there's a huge variation each year in input. So going back to Anton's point, we're very involved at that national setup in terms of looking at, there were certain things to do with allocation, because the problem with our system is that the vacancies are distributed a little bit unevenly. So when you have attrition, it tends to be our rural areas that are hit harder, always, and we had significant numbers, which is why we focused pilots in Coilbar and Betsy Cadwell this year. So there's national stuff going on about the allocation. As Anton says, next year it will be based entirely on preference rather than a sort of whole other complicated assessment. And because of the numbers of posts we have in Wales, any trainee who puts Wales down as first choice is going to get allocated to Wales. The historical system actually did mean that a relatively small percentage, were pushed out from Wales because they scored less highly than others who had Wales maybe third choice. And that was a slightly uncomfortable situation for us. So the change in that national allocation will help us. And I think, just to be clear, we're also working with our medical schools in terms of that alignment. We have, with your support, ensured that we have sufficient foundation posts in Wales to accommodate all graduates from medical schools. We do not want the Republic of Ireland position where the people who would want it. But currently our attention from medical schools is variable and not as good as we would like. So there are local things going on, but more importantly, that national thing. And this withdrawal rate reflects what's happened elsewhere in the UK. So largely down to the international medical graduates, which we can't influence. A lot of whom just don't turn up on day one. So you're left very, very much with a last minute issue, and they're not in our jurisdiction to actually.
Thank you.
Thank you. I really like this report. I think it's great. And particularly if we can go, if we want to the detail behind it. But on the face of it, this is great. To add to the discussion, I just wanted to raise the point about the inequitable distribution, which is hitting rural areas. We've got a problem in rural areas with staffing anyway, right up the system, and it just seems particularly sad that we can't sort it at the not quite at the start, but early on.
I know it's not.
What we need to do about what do we need to do about it is the question.
Do you want me to answer you?
I want you to answer, but I think this is not a problem, a challenge only for Wales. This happens in all the areas of the UK, and it's all about geography, isn't it?
Yeah.
But there are some things that
Yeah, unfortunately, because people can apply and choose in terms of where they go, and the culture in the UK is urban centric at this stage. And if you look at the attrition withdrawal rate, it is reflected in that. So we have posts evenly distributed. In fact, the distribution of our foundation posts favours the rural areas, and the incentives attached to them are concentrated in those areas to try and attract people. But the withdrawal rates, when the eventual allocation happens, are significantly higher from those rates because of individual preference. So it's not our allocation system, it's how people's behaviour is about where they want to be. And of course, what we want is for doctors to go where patients need them. And this is a very strong focus across the UK in terms of discussions of how we do that. England are actually redistributing their posts out of London because they've got a very heavy weighting. We're not in that position, but there are the numbers, there is still that issue about we put people, so the foundation were full in all those rural areas. But when you look at that 61 withdrawal, it is heavily skewed to those more remote health forces.
I mean, it's quite sad in a way.
It
I
is.
don't know what we could do to unpick it, because it is satisfactory.
Well, I think the key is starting earlier with, so as the North Wales Clinical Medical School, for example, set up with that fundamental purpose of retaining all that area, we are involved very much in discussions with those medical schools. I think part of our problem now is that the foundation don't have to stay in the area that the medical schools train. So we only retain 50% from Cardiff University into the Welsh Foundation system of the graduates in any year, about 50%, and that's increased. I think we are looking at methods potentially where you could align your mental, and that's partly as part of the national discussion, but there are things that we're looking at. So it's a very high priority, but there isn't an easy solution to it. What we can say to the committee is our incentives and our distribution of posts don't reflect where we need them to be. It's just trying to encourage people, but it's actually a good place to train.
I think it's useful you're looking at it, maybe in about 6 months or a year, we can have that come back to the committee to see whether any of the suggestions or the changes that you have has had an impact. I have a question on that specific issue, and I'll come to you, Donna, if that's all right. I just wondered whether, looking at where those individuals want to place, whether is that to do, have we had a questionnaire or an engagement with the students to see whether they want to work in an area with a tertiary clinical skills delivery, as opposed to general medicine in inverted commas, you know. So sometimes when you're talking to students at that level and they're trying to determine where their career is going to go, if they're in a tertiary centre or somewhere like the Heath or Swansea that's got Burns, that's where their area of practice is. And if we enhance the placement, would they remain rurally? I just wonder whether those type of questions for not wanting to remain rurally, is it to do with what's on offer medically and the clinical challenge?
It's not. So there's a lot of that. I suppose we both mentioned this was a UK-wide issue. It's not. It's a worldwide issue, and it's the focus of a lot of discussion and conferences. And Canada, New Zealand, Australia in particular are areas we work closely with to look at the initiatives. Now, the advantage they have is they really are remote. Problems we have in Wales, we're not really remote. We have rural areas, but you're always within an hour or so of a hospital, and people can travel. So there are slight differences in terms of that, but we are working closely with that. It's much more to do with geography and the nature of what they do.
Okay.
Is the answer to the
So we-
surveys we have.
so we have that-
We have that, and I will also reassure the committee that the medical schools who we do not have direct responsibility have done a huge amount of looking into this and the intentions of their students, and have restructured their programs to embed people in the students in those rural communities for much longer. So this is the evidence that came out of Canada and Australia and New Zealand, is if you place students in the community, you worry less about ticking that they've been in theatre 5 times, because the clinical competencies you acquire can be acquired generally, and you place them in those communities for much longer periods. So that is happening. It takes 6 months, we can update you, but it takes much longer, Chair, for information to come out. We are then reflecting the changes in the medical school into what foundation programme structure is. We talked before about longitudinal placements into communities. So although they change every 4 months, they have, so in North Wales, they have the mountain medicine throughout their year as part of their whole year there. In West Wales, they linked in with the lifeboat service and the rest. So really giving people broader opportunities that bring that embed them there.
So going forward, what would you suggest is a reasonable time for the committee to review what actions you're
Well, I
trying
think
to put in place?
it's reasonable to have updates fairly regularly on where it's a fundamental issue. I think in terms of outcomes, that's a much longer thing. But if the committee wants more information on what we're doing to support that, then that's certainly something. we can talk
Go on a
about.
year's work plan, maybe a year from now.
Yes.
Yeah, okay, thank you. Donna.
Yeah, actually, you answered one of my questions during that conversation, which was, the follow-up and surveys and how you know why people are withdrawing, etc. And just a small point, but you note in the paper that there's some consideration being given to a second entry point in February. how is that going? Are we likely to see that, and how are we going to make sure we get a good, you know, so those people coming to us then?
Maybe I'll pick that one up if that's okay, Anton, because that is a national issue. So part of the problem with foundation currently in medicine is that August is the only entry point. So anybody who's looking at it in August have to wait a whole year before they can come back in. Now, there are complexities with the programme that are around that, and there are unintended consequences of having other dates. But for exactly the reasons we've just articulated, which is some of the international medical graduates not coming over related to visa challenges, timing, and they can't get there for the August, we will defer and give them a little bit of leeway, but you can only go so far. And those students who fail finals, then retake it September, October. I think realistically the date would probably be December to allow where you change. So we agreed across the UK yesterday to scope that on a national basis of what a second entry point might look like, and the resource required to implement it, which if I tell you that there are nearly 11,000 applicants to the foundation programme across the UK, you can imagine what a recruitment process for that looks like. We have 450 of those, but we hit 10,800 applicants for places. So that is an all year round industry preparing for that recruitment, and we've just got to work it out. There are also unintended consequences associated with that. So I am slightly concerned that if we don't get the criteria right, that people qualifying in August will quite like 4 months off before they can start in December. And actually we end up causing ourselves more problems than we solve. So it's something we are in agreement that should be scoped, but I don't think we should look at it necessarily as something that will solve the issues that we're talking about.
Very helpful.
There's one further question I have in selection. I just wondered, given the multidisciplinary approach that we have on other healthcare programs, is there an opportunity for physicians associates to have accreditation prior learning to step onto the medical degree? Have we looked at that? Because if they're already domiciled in Wales, is that a way that we might have people working in rural areas?
I don't think that's been looked at yet. I think the GMC are really worried about getting on board in the first place,
Yeah.
and all the adverse press that they're receiving at the moment. So, having said that, you would think that it would be possible, because especially when you look at somewhere like Swansea, you know, they've got a graduate entry program for medicine, they've got a graduate entry process for physician associates. A lot of their teaching is joint. You'd think that there would be some credits for some of that to be able to be put forward to a medical degree. So we thought about that in Wales, and it's certainly something in the career section of Julie's directorate that thoughts been made, but not just about physicians associates in medicine, but many professionals.
That's why I'm asking the question. Yeah.
So we've had the discussion. We'd like it to be possible, but I think that until the GMC have incorporated them from a regulatory point of view, I don't think they're in a position to incorporate them from an educational point of view yet. I think it's
I suppose just with a general point in relation to that, the previous restrictions we had in relation to the number of hours one had to train to complete a medical degree is no longer the same. That has changed with all the changes in European legislation. So there is further work going about the UK about the length of the medical degree and whether it actually needs to be 5 years at all. That links with other professions feeding into that, because currently we are very much tied by previous restrictions. So we're working with our medical schools about the duration and how feeder streams, etc. link in.
Okay, so thank you for that. I just think that in terms of the organisation, if we're looking at it in other professional groups, the question should be asked for medicine in terms of access and accreditation prior learning. And I would take on board the regulatory agenda, because it's the same with the regulators in the other professions. And they really have to look at it because their role is public protection. But realistically, if you haven't got the numbers coming through medicine and you've got people in that, why wouldn't you look at that? So maybe there's some work to be done there.
when I raised it with the head of PAs in the UK, they bolted and said, no, we want to be physician associates, that's what we want to be.
And there will be people
So I
that
said, okay. So it's a bit of a raw nerve when I raised.
Can I just make a quick comment? It's about the linking to inequalities. We want to be sure that we aren't ending up staffing our rural areas with physician associates who haven't got sufficient support in the medical sense, or, you know, that there needs to be a proper balance maintained so that we don't drive worse inequality. By assuming then the work can be done by others.
Yeah, and one of the points in raising that if they are physician associates domiciled in those areas, the opportunity to become a medical practitioner should be on the cards.
Yes, so I think, the widening access agenda is front and central with all the medical schools, and, the issue about representation of your community. The makeup of the teams that serve it, reflecting the communities that they serve, is very much part of what they're being judged on.
I don't want to imply that I'm not supportive of physician associates, because I am. It's just a thing to. They need to have a proper place in the system.
There's no shortage of applicants to medical schools either, so it's a challenge. We're still somewhere around 5 to 1 in the Welsh medical schools applicants for places.
Okay. Anything else before we move on? Oh, sorry, was somebody else sharing? Sorry, hands on. Okay, yeah, I was gonna come back to see where you are.
No,
Okay.
I'm next on my list is the
Yeah.
something brief about the trainee and trainer survey. Is that what you were expecting?
Yeah.
Good. There's a few lines about the GMC trainee and trainer survey in the report. This really does not do justice to the work that's going on behind this. There is a small team of people who've been working really, really hard around the surveys. So just for those who's not aware, I'm going to try and be very brief, and I don't want to go, I'll wait for questions if there are, but the GMC National Trainee and Trainer Survey happens once a year, every year. My personal feeling, and those from some academics, is if your survey doesn't get more than a sort of 60% response rate, you really can't take big messages from that. Wales has the highest response rate year on year in both the trainee survey and by a huge margin in the trainer survey. So we've got an 88% response rate for trainees and 60% for trainers. So we can take those findings and look at it. A survey, and I will quote some of my colleagues in quality management, doesn't tell you there's a problem. It doesn't. It just tells you where to go and have a little look, which is exactly what we do. So the surveys have happened. The data was released in July. The quality unit scrutinized that data. The results were sent out to education teams, shared internally. Meetings have taken place with everyone involved to create action plans. I'm making a very big process very short. There were also some pretext opportunities for trainees to write down things that they wanted to do about things that worried them or patient safety issues. Those things we did not wait for the survey to close. They were acted upon within usually about a week, and then liaised with the LEPs to address those. They weren't huge amounts, similar to previous years. So the next steps for us now is to work on action plans together with our LEP colleagues to address or go and have a look at some of the issues that may have come out of the GMC trainee and trainer survey. This gives us a signal. Triangulate that with some other data that we have, because we would never only look at a single source of data. And then we have plans in that for that. So this is an ongoing process, and we just presenting today a snapshot of what's happened. So
It would be helpful to hear further about it when more time to invite her. If you've got more information later today.
so
We've got a snapshot here, but
we've got a snapshot, and we know what the some of the key themes are that's coming out of here, and then there will now be a series of visits around quality that takes place, and those will definitely be reported here back at ECEC.
Maybe that would be helpful. Yeah,
Okay.
thank you.
Yeah, just, thank you for that. In the issues that were flagged up, and I know later in the report you talk about the speaking of safety and at the first meeting of the supporting trainees, and on the back of the independent report on reported sexual harassment, had any of that filtered through in any of the reporting that we received?
Maybe sadly, no. We don't get any, we did not get any, we have always have some pretext comments around bullying in the workplaces. But to the degree of the current things that we hear from reports that's coming out from the surgery, etc., we have not received anything in that kind of severity. Not only not through the survey, but through other channels either.
But we've got the first meeting, and presumably at some point we'll have some feedback from.
So we had the first meeting last week. It's clear to me that incidents like that are happening. The concern, the overwhelming concern that was voiced by all those who had either experienced it or knew of it happening was the reluctance to report. So that is alongside what you just said, but we're not going into that. We're not doing any more surveys on this. The evidence is clear, is there, and we're going to take what I hope will be a strong approach on how to provide channels of communication for those who are victims of this, so that they can raise it safely. Nearly all of them, or the majority or vast majority of them, are concerned about how it impacts on their careers. Well, there's something wrong there, isn't there? So I think when we had the first meeting, it was interesting because lots of other areas of discrimination were raised as well. So what we decided between Tom and me is that we're going to have an oversight group with some work streams underneath, one specifically on sexual safety, another on racism, another on gender bias. So I think that's how we're going to approach this.
Thank you.
Just thinking through what you said, questions, and I was part of the group that started the whistleblowing legislation, and ever since that was brought in, the same issue has remained, which is the scare factor, I think, in people's career and this reporting things. And I don't think that should be underestimated. Nobody wins out of any of these situations, and people are very reluctant to come forward. And you can put in place all sorts of things that try and protect them. But at the end of the day, if it is somebody in a senior position who's the perpetrator, it's very, very difficult.
We've got to find a way around that.
Yeah, and it's been like that, and I've seen so many people have their careers ruined by reporting, but it just doesn't happen, and that's clearly what's happened here, because otherwise you'd have had some sort of idea that some of this was going on. So I think there has to be some radical suggestions as to how protection is afforded, and a lot stronger in terms of perpetrators.
Well, yeah, and
Because that doesn't happen.
and that came out strongly in our first meeting.
Nothing generally happens.
Thank you, Jim, but in response to that, I think it's not only in senior positions. I think it is a cultural issue. So therefore, you can actually help people that are in a way dismissed at a lower level in the organisation. So it's not just at that senior organisation. So if you think of the concerns that we've got in respect of our pre-registration students, it's basically not even that you know where for not sure whether they can even raise it at that ward level. So there's a cultural issue here, there's a leadership support mechanism in it to understand that you want everybody's responsibility is. So I hear what you're saying and I know what you're referring about, but nevertheless, I think it's not just at that level. No, it isn't. Yeah.
So in terms of taking this forward, what do you propose bringing back to this, so that it gets some assurance of some action on?
I think that
Difficult question.
exec team is on this this particular issue. So I think that that's where we're taking. I've agreed with Alex the approach over this slowly. The key thing for her is that we have some timescales for getting that work completed. So I think we'll be going back to execs with that on a regular basis. But I think this is a board issue as much as anything else.
And is there issues for resource from the organisation to help with that?
Not yet. Don't know yet.
So that will be incorporated within the executive discussions to make sure sufficient resources.
Obviously, that's a professional issue. But it's involved in the profession. I think it's.
I mean, sexual safety for female surgeons, largely female surgeons. Well, there's lots of other females in the same environment. So it's I can't think that it wouldn't be impacting on them.
Okay, so it would be useful, David, to maybe have a discussion if the committee are happy with the chair, to see whether this is something that the board should maybe have a board development day once the work is completed at executive level. If it's a risk to the organisation, then that should be escalated to the board by this committee in terms of responsibility for the actions to be taken. So we're content with that.
But obviously there's a problem of work on this with your sector. There's just holidays that you need to come and do that.
Yeah, that's what I'm saying. If that will come in the work, the executive team.
Yeah, definitely.
So, yeah, so a number of things we've changed, so we have got a separate piece of work on safety in the paper, so that's the board last time. We're providing regular updates going forward to the board with regards to the work that we've taken in this area.
I think that's extremely helpful so that we know, because this is a risk, and it's been helpful to have the comments and discussion this morning around that. But then for this committee to ensure that we're mitigating that risk is to put it back to the board. Yeah. Okay. People content with that. Okay. Thank you.
No problem. I'm going to move on briefly to quality management and looking at some areas of quality management. Again, I'm going to be very brief. There is a literal industry of work behind quality management training. As soon as you write something down on paper or you put it in a spreadsheet, it's out there. But I will say that this recently, the last quarter or so, we've done some targeted visits. In other words, and the details of those are provided. When we go and visit a LEP training partner, we go because sometimes on request, sometimes because of a concern, sometimes just to gather more information. And when we go and engage, we will meet, and this is important, trainees in the workplace, together with their trainers, folks from health board management, often including some of people in senior managerial positions, where if we go to a visit and it's not possible to meet with the trainees because none are available, we would usually reschedule and not reduce, for example, a risk until such a time as that's been possible to do. And we share recommendations rapidly and then put in place action plans and then go and revisit and see how we can help to make that happen. Enhanced monitoring is something which is usually recommended by sometimes the LEP themselves, often us, and agreed with the regulator. as Bush pointed out before, the regulators not yet disagreed with some of the decisions that we recommend. In terms of enhanced monitoring, it's great to note that 2 training sites were removed from enhanced monitoring, and it's quite, I should say, easy to get into enhanced monitoring, difficult to get out, but that's oversimplifying it, but it's true, because even if you are improving in it, when the regulator is looking, they would keep you in enhanced monitoring correctly to see sustained improvement. So the fact that 2 training sites or 2 training areas have managed, we've helped them to manage to get out of enhanced monitoring is indeed correct. There are currently 3 other areas in enhanced monitoring, and that's described in the appendix. In terms of high risk concerns, we've got a 4x4 matrix for assigning risk, and there has been some sites with high risk containing sites, and they are also in the appendix and in appendix 3. And I'm not going to discuss them individually. I'll wait for questions if that's okay. Unless you want to discuss them individually.
No, I think we'll take questions because I'm interested also in making sure we keep time. So thank you, but I don't want to dismiss the areas of concern. So I'll open it for questions on that particular topic.
I don't have any questions, but I just wanted to say I think it's very helpfully presented like this. And first, we'll take the first time, but it's actually really clear. You can see our way through it. You can see it also as a whole, which is important. Yeah. Thank you.
Would you say that the 2 areas that came out to be monitoring were both in the Mason Hospital, and they achieved that within short time of each other? So good for that.
I think that's a very positive issue, and I take on board what you said about how difficult it can be to come out. So it is important that we acknowledge that, and also the work that's gone on to get to that stage. Yeah, because you can't underestimate just exactly the impact that will have had on the organisation and this organisation.
Which also shows that the system works.
Yeah, yeah, there's some assurance in there. Okay.
Yeah, one very quick question. I'm trying to keep the time as well. So sorry. Do you do impromptu visits? I noticed that a lot of warnings given them on the bit you said really smooth.
For example, like CQC or no, we do not currently. That could have another huge resource implication, but also impromptu visits in medicine is quite tricky because there are huge variations.
They're all in service.
How
to that.
But again, some of those things could be picked up by the healthcare regulators, HIW. Yeah. And healthcare aspects where, we do live. Yeah, there should be that. Okay. Anything else? So in terms of the recommendations, members are asked to note this paper, an overview of the current risks and exceptions in relation to postgrad medical training and our organisation's actions taken to address these, and also to note the positive exceptions in progress. Yeah. And it's commendable that the members of the committee welcome this report and the detail within this report. So the assurance that can be gained from that is very positive action for the auditors of the report as well. So thank you. Okay, so are we moving on to dental now? Bush, are you?
Yeah, I'll just invite Kirsty to continue, if that's okay.
Thanks, Push. Thanks, Chair. I'll take the report as read. As Push articulated earlier, we're in a different position to the medical deanery. We've got a lot of ex-trainees, but we also don't have the quality teams in the same support in place. Although we are addressing that, we've now put in place a quality lead who will take up position properly in January and take all of this work forward to make sure that we're aligned and reporting. This is a journey, as Jill said, and this report is part of that journey. And I recognise that there's probably going to be some questions as a result. Recruitment is generally quite positive and in line with what we expect.
We've taken some positive steps. We've taken some posts out of national recruitment to recruit locally to high need rural areas in Wales, particularly foundation training. That was piloted it this year. It was very positively received, and so we're expanding the offer next year. We'll increase the numbers that we take out of national recruitment to 16, and we're also increasing the rural incentive grant to mitigate the salary difference between nations to try and improve recruitment. We're having conversations with North Wales Health Board, particularly about longitudinal offers, because in respect to the conversation you had earlier about early careers dentists and what they want and their aspirations, they don't want to do what the system is designed for necessarily. So we recognise we've done a lot of work, our clinical fellows have done a lot of work with final year graduates, focus groups, identifying what their aspirations are. And they want security of salaried roles, they want longitudinal positions, so they've got some security over a number of years. So we're trying to put some of those things in place to make it more attractive, working with health boards. So foundation training, I think, is generally very positive, and we'll continue to make sure that that's the case, and that we're not adversely affected, particularly in the rural areas of Wales, as we previously had been in previous years. Dental core training is challenging, and you can see from the paper there, the recruitment's reasonably good, but some challenges within that in terms of the locally recruited posts that then maybe overseas dentists, and because we're in a regulatory position with the General Dental Council, that's quite challenging because they have to have temporary registration. We find some delays in starting. We've got meetings with the local units and the HR teams to try and mitigate some of the challenges that have surfaced in the next round. But in England, they take the decision to not have those posts available for overseas registrants, whereas we took the other position and made all our posts available to overseas registrants. The unintended consequence of that was the additional work in facilitating it. So we're just managing that and working with the units in that respect. Oral maxillofacial surgery is particularly where we see the most vacancies in dental core training, and that's a national problem. And as the paper says, in some areas they've reviewed that and looked at alternative provisions. I'll have those conversations locally with each unit, because we will meet with them and we'll talk to them about what they want to do, particularly where posts year on year aren't filling. And I've got a meeting this afternoon with North Wales Associate Medical Director to have exactly this conversation around what can we do, how can we improve the recruitment to these posts and make them more attractive. So that's a national thing we're seeing. Specialty is very positive in Wales. We've had a significant investment, as the paper says. We couldn't put all the posts we wanted to in place because of system constraints and units and capacity. So we diverted the funds for a year to try and maximise recruitment, and we'll continue to work with health boards and units to put those posts in place going forward. And we know that there's high needs in special care, specific specialties. There are high needs that we need to address, patient need, the growing population, comorbidities, etc. So we will continue to do that. As you mentioned earlier about the multi-professional, we've got dental therapy foundation training, and I'm pleased to report we've recruited a dental hygiene therapy lead, and there's quite a lot of work going on in this space with this particular area of the workforce, because it's I think the Minister is very keen to see expansion here. Our dental therapy foundation programme, we increased to 20 places for 2023. We've recruited 16. In England, they folded quite a few of their programmes because they simply didn't recruit them. So that's really positive for us in Wales. We're doing some early work on kind of looking at where the graduates are going and their transition. You can see dental therapists coming into the NHS through our foundation scheme. Hygienists are tending to go into the private sector. So that's one of the challenges we're kind of addressing. We've had agreement that the dental therapy foundation programme can be at a time for the bursary. So we'll work with those who take the bursary to make sure that we can draw them in. And then in terms of commissioning, some really positive news coming out of commissioning. We work quite closely with Martin and his team on the commissioning. We've agreed, and I think it's hot off the press, and I'm not stealing your thunder, Martin, that dental therapy at Bangor University will be developing a one-year conversion programme for hygienists to convert to dental therapists. And that's been agreed through the programme. So we're just putting more mechanisms in place to make that happen. So that's really possible. So we'll have Bangor and Cardiff both training dental therapists to expand that workforce So some really positive things, dental nurse training, still challenging for all the reasons the paper says, well, governments and apprenticeships, but we're optimistic with the introduction of the CTER, that might change, the landscape might shift. We work with all the stakeholders that deliver dental nurse training, and while we don't have locus of control necessarily, we will make sure that we've got the relationships and the data. So that's a work in progress, dental nurse training, but one that we will continue to pursue. Training work live is ongoing. We're having conversations with Chief Dental Officer and the team around overseas, essentially looking at drawing dentists from overseas and how we can facilitate that, support that within the regulatory constraints of registration. Our engagement educational supervisors, we don't do a trainer survey yet. However, it's one of my to-dos. So we will be doing that. We do engage with them frequently, but within each programme, and I think we need to do it more as a faculty. The paper then sets out how we engage with all our educational supervisors. Dental foundation training, we had a very, very effective day last week actually, with them, where we get all the education supervisors and the trainees all together and do an educational programme, really valuable, and core training, and then we meet with the units locally as well. Dental trainees, we have dental trainee forums. The chief execs attending next week's dental training forum to talk about duty equality with the trainees. So we're driving that. Dental training survey. So this year we revamped the dental training surveys that we've had in dentistry. They've always operated in each programme in isolation of anything. So we've done an overarching programme. This is an initial snapshot. We're still doing the deep dive and pulling the full report together. But it's generally very positive, 67% response rate, which we're quite pleased about. Generally very positive on HAW, some challenges around single lead employer and NWSSP, which we're addressing. In fact, our clinical fellow who oversaw the surveys and managed them is meeting with the medical director of SSP to talk specifically about some of the issues that were surfaced. No significant issues to report in terms of progression or trainees. And then you can see what we're doing in respect of the surveys and some of the feedback. We've got meetings next week, particularly with Cardiff as the unit, and meetings with Income Tap as well to discuss some of the issues that are surfaced there. But that's again ongoing piece of work, just as the survey being put together and we're identifying where there are specific issues, but no major safety concerns to report.
Okay, Kirsty, thank you for that. Any comments or questions?
Thank you. The picture you present, because it sounds a little bit more optimistic than it did maybe 12 months ago or even more recently. So that's hugely encouraging. Of course, the fundamental problem originally for the person on the omnibus is access to dentistry. So it's the pipeline is an interesting thing to think about. I'm just wondering if it is better when some of this benefit is going to work through into access. And with that, the balance between NHS and private. So you mentioned in the report the work on destination of students and not just foundation, but all the dental professions. And I think getting data on that's absolutely crucial, so that we know that we are training to provide that access. And I think there's some quite positive news about community dental services, which is good. And children's dental services has also been an area of worry. So it's good to see progress. I'm sure it's been a massive amount of work on this to get where we are. But keep going. And I think the impact on the pipeline is something that we need to understand as soon as we've got the information.
Thanks, Chair. Yes, I agree. It's one of our actions from our workforce plan is that data, because also for them it's the skills mix, because you know we're training. What's our skill mix like? Where are we deficient? What do we need to train more of? And headcount isn't going to fix the problem for us. So with that skill mix, I think is particularly important. So we're going to look at that as well as the destination data. But the mixed economy dentistry is really challenging because we know that more graduates are going directly into the private sector. Yeah.
Yeah, I think that's something we need to really understand what the definition on that, and also what it means in terms of inequity and equality.
I think that what Ruth is saying there is that we've asked for some time across all of the professions to have first destination. I know Sian is producing some of that. That's something the committee does need to look at because of where the impact of the people in training and the retention factor, but then the delivery of services within the independent and private sector and access to the NHS. Aware of time.
Two things. One is in contrast to medicine, the foundation year isn't compulsory in dental, and it isn't required for registration. They register at the point of graduation. That's a key difference. And the second thing, we don't commission undergraduate dentistry, so we don't necessarily have the information of a destination for those, but it would be helpful if we did go that way.
Yeah, I think if we haven't got it now, we should have it. And we need to find a way to enable it.
I know this is some of the chair of the board said at that board meeting in relation to meeting with the minister with regard to the foundation training. But again, the rest of the UK don't offer it either. So there is also that issue. If you bring it in Wales, what that would happen. So the impact of all of that presumably will be work that will need to be undertaken. Okay, any other questions? Jill?
It's just a comment really. I mean, Ruth picked up most of what I was going to say, which is the positive picture. I'm really pleased to see that. The landscape appears to be getting more confusing in terms of the different parts of the system moving, and the pipeline incredibly positive too. But the elephant in the room is the pipeline into the private sector. I just think that we need to focus some attention on, is there anything at all that we can do in terms of, obviously we can't rewrite a dental contract, but a sort of pressure on incentivizing, and I can see what you're doing in terms of building an alternative market almost, but the elephant in the room, I think we've got to start putting words on paper about the impact.
And so the chief dental officer has been tasked by the minister with writing a 10-year plan for dentistry. So you mentioned the contract negotiations are ongoing currently, and not any significant difference to the existing contract. The 10-year, so his 10-year think piece I've seen, I've commented on, and I've given feedback to, but I think you're right, the data is that's the gap. That's the gap, you know, it's what we anecdotally know, and we've got data on NHS, but the private sector data is, you know, is you know, where is that? So yeah, I definitely think data is our greatest challenge right now with respect to this.
Okay, so in terms of taking this forward, I'll ask the question: is this something that the GDC can actually look at? Because it's a regulatory issue about the year post qualification. And if they were instilling certain standards, is that something that could be influenced?
So GDC have always historically, as the regulator said, that their role is in workforce, always, that's the position they've taken. However, they've changed, they've turned about face and said, oh, we recognise we have a role, safety and quality, we recognise that. There's a workshop next week that I'm attending with the 4 CDOs, the chair of Dental Schools Council and the chair of COPED, and I'm attending that next week. So that's the first look at that. I don't think the GDC data will give us what we properly need, but it's without doubt a starting point. We are better, I will say, at workforce data in Wales than they are in England.
But as a regulator, we've got the core element of that. And if it were instilled across the UK, then it would be easy to implement it with that there is that sorry, I better shut up. Right. It's an area to influence. Okay, thank you. Firstly, there was one other question very quickly from my perspective. The cultural challenges with regards to trainees working overtime and not being paid. in some units. Is that across all of the people we commission or?
So we need to dig into that a little bit further.
Okay.
And we need to dig into that a little bit further. The trainee, so we were having early conversations with the trainee specifically and just identifying if it's in particular areas or across every unit, and is it a people issue? Is it so we're just finding out a little bit more about that specifically, yeah.
Because in terms of wellbeing and corporate responsibility from our contracts, it is important, so thank you. Okay, so in terms of this paper, members are asked to note the report for information assurance. And also, again, there was very positive comments from the committee members in relation to the paper, the content of the paper and the effect that it's having, so thank you. But there are some key areas of development which no doubt would be reflected in the minutes. Gary.
Thank you. Just want to remind presenters that they can assume that the papers have been read by the committee, so we could keep the presentations concise, so we can focus on the monitoring and scrutiny committee.
Okay. Right, we're moving on to pharmacy then.
Jealous you, Margaret. I think what I'll say about where we are at pharmacy at the moment is that we're in that peculiar position where we just recruited to nearly all of our programs. We haven't got any issues with any of those trainees as things stand, so there's not that much for us to be bringing to the committee on this occasion. So that's if you want to say anything more, Margaret.
I think there was two things, but the main thing for me is that there will be a lot to come to the committee next time. So while it's quite basically in the nicest possible way, I think I go first. But yeah, there's a lot happening. So from our point of view, we're going into sort of crucial phase now. So from the point of view of the foundation training changes for 2025. We're going into that final push now. We've just been out to a consultation on the changes. I haven't got time to bring it to this committee. It's all going to happen next time. But I think the critical thing I wanted to say that the quality management of our foundation training will rack up considerably because the regulator, we were going through our step 3 accreditation in May. We'll be preparing for it in the next quarter. And that accreditation panel is very similar to an MPharm accreditation. So it's a full panel. We have to provide a lot of documentation. So it's significantly different. We're not worried about it, but we do need, one of the things we're worried about is being able to show that we have the resource to be able to manage that quality enhancement that will be required, right? So that's one of the slight concerns, that we won't get accreditation if we can't demonstrate we're going to have the resource to manage that. I did just quickly want to give a bit of good news as well. That last time we presented, I didn't have time to put it in the paper because it's come off literally this week. We said that the pass rate for our registration exam in July last year, June-July last year, was 81.7%, I think, and we commented that normally it's in the 90s, but it was a UK-wide drop. However, I do want to report, and we'll bring it back for formal reporting, that we've had the second sitting of our paper in November. We have a 97% pass rate, which means bar 2 people, everybody passed. That's compared, I haven't got the English comparison. Scotland was 65%. So whilst, you know, it was a blip, but we have actually got everybody bar 2 through that second sitting. So I think that's a really good news. And just final point, because I'm conscious of time, as you already know, our recruitment to our programs are generally very high. We are waiting to see what the recruitment is for 25-26. Again, we'll report that next time because it's going to come out anytime soon. But we are looking at, and it's mentioned in the report, how we could, it's not about filling, it's filling with the right people, because what we're doing is, because we have a premium product in Wales, which everybody wants to come to because of the way we manage it, then we are not necessarily always getting the people who actively want to come and stay in Wales. So which is why we're looking at the ORIO recruitment system. So we will present that back as well next time as what we're proposing to do to try and make sure that people are actively choosing Wales because they want to come to Wales, not just because we've got a great programme. So I think that was all I wanted to say, other than we're on a journey and we'll have a lot to say next time.
Okay, thank you. Any comments or questions? John?
Just very, very quickly, Chair. Thanks, Margaret. That was really useful. Because of the balance, isn't it, between attracting all the best and those who want to stay. You've got to be careful not to dumb down anything. Just because people want to stay in the nicest sense. So I just had a very quick question on the quality, how we look at the quality of prescribing pharmacists. It was just something that occurred to me that wasn't, I couldn't see it in the paper. So it's a fairly new concept, isn't it? New, that there are more of them now out in the community. Have we got a quality programme around them in particular?
It's interesting. It's interesting you asked that question because literally had that conversation with my senior team yesterday. We are looking at a proposal for next year to look at all of our independent prescribers and what we can do to support them once they are prescribers. So not just saying, right, you're a prescriber, off you go, but how do we support them in their skills and how they actually provide patients. So we have some good quantitative data from the point of view of the difference they are making in the NHS, especially in community pharmacy. We know there's been over 100 independent prescribers in community pharmacy, with patients saying if they hadn't had that service in community pharmacy, they would have gone to a GP or elsewhere. So we know it's making an impact quantitatively for patients. What we haven't now done is how do we qualitatively support them to develop even further. So
I think that's quite an important question in terms of the impact of training and the impact on other professions by having that skill set, especially what we see all over the place is the problems of accessing GPs and the impact on science and patients. So to see what this particular innovation has done and to be able to bring that back to the board would be very helpful. So you've only just started discussing the time frame for maybe accessing some of that. But how far access but to bring something back to demonstrate the impact.
Yeah, in relation to that. Yeah, but it needs to be minded, and independent prescribing has been around for quite a time. Yeah. So let's not forget that. So to be fair, you know, a number of the other professions actually introduced independent prescribing. So to be fair to Margaret, you know, why are we actually focusing? I think actually what Margaret is actually focusing on is actually the important aspect is the supervision and support actually when they become independent prescribing, because it's very difficult because everybody prescribes within their scope of practice, and it's not always easy to measure against such each other. So I think I'd be cautious as in saying what that quality metric is. Like if we from nursing, that's on the regulated on the NMC register, and they have to be validated in terms of how they're actually updated. So I think we're actually going into the minutiae of individual professions, and that could become an industry. So to be fair, I think actually what we're learning is learning how what sort of Margaret is putting in place, and applying it to elsewhere. That we've got advanced practitioners already across the board who are doing independent prescribing, and we're having for years, and we're still training them. So we shouldn't focus on a unique professional approach.
I think what might be worth bringing back to the community is that we do have a steering group looking at and prescribing and looking into the quality lens, both from the point of view of commissioning and then supporting and, you know, getting them the skills in the first place. So I think that's only really in its infancy. So I think we need to look sort of maybe 6 months down the line when we really nailed what is that, what does it look like, and that is for all independent prescribers. It will apply to all of us. So I'd be happy to bring that back to.
Okay, I think that would be helpful. I think there's two discrete, well, there's two parallels for me here. One is that as a committee, we have invested in the changes in pharmacy, which has insisted that all pharmacists become independent prescribers.
Yeah.
So it's the impact of the investment that we've had on that in terms of the quality that I think Jill is kicking into action. The issue with the multidisciplinary access from a nursing, physio and OT perspective is also the wider impact where we have then gone into multidisciplinary, which I think would be helpful from, you know, the combining elements of that. But in terms of where we're coming from is the commissioning and quality element of that. We have invested quite heavily in new pharmacists and also historical pharmacists in the community. So that if we can actually demonstrate where we have commissioner training and gone in line with the regulators, that gives us some evidence when we're coming from another perspective, when we're trying to bring something in. So I think the two parallels are there. Yes, there's the most definitely the multidisciplinary approach, but there's also the quality and the impact we've had from the additional investment. Yeah. So that's the bit that I'm asking about, satisfying the
So that
objectives of this committee.
that you could bring certainly where we are now and what we're seeing already happening, which I know is being reported to the First Minister as well. So that information is available.
Okay, and I think that helps also in some of the issues that we've discussed at board with regards to maintaining the GP numbers and the commissioning of those.
Yeah.
Because of if it's affecting how clients are receiving, it links to dentistry and the access of all of that. So the quality and the improvement element fits into a more broad collective. Okay, right. So if we're happy. Oh, sorry. Okay.
A small point, I'm sorry, it's my own.
It's such an interesting topic.
Yeah, no,
Topic for the committee.
Yeah, this is my own lack of understanding, so apologies, but it was under your regulatory update and you talked about a small number of or a small risk of having foundation trainees on the old learning outcomes rather than the new. And the schools fancy refusing to make adjustments.
Yeah.
I just wanted to know numbers and impact really. What it actually means.
I don't think you want to answer that.
Oh, right, okay.
We've been asked a hospital pass by schools of pharmacy. So the regulator made assumptions that schools of pharmacy would get all of the students through either on the new and the old learning outcomes by 2025. That they would do that. So they would bring everybody in line by 2025. The university said, oh, no, that's too difficult. It's too resource intensive. We're not doing it. So they passed it over to the education. Now, what we're told is they're very small numbers. What we know is there are no students in Wales who are going to come out on the old learning outcomes. None. So from selfish Welsh perspective, there are none. However, we know we recruit from England. So without delaying conversations, I'm happy to have this outside, but we're sort of being pushed into a situation. We have to make plans now to be able to have small numbers or no numbers, but hopefully small numbers going through on the old learning outcomes, which means in 2025-26, we'll have some coming out as IP and some not coming out as IP, which is not.
Yeah, I just wanted to understand the scale of the discussion.
And the regulators would be most unhelpful in this.
Yes.
So it's the first thing. The second thing is it ties in with the other thing that was mentioned is the oral recruitment.
Yeah.
That is so we can recruit people in Wales for Wales who want to stay in Wales. So even if we recruited less, at least there'd be the number of staying would be high. That's the issue.
So we were hoping to disaggregate from the English recruitment for 25-26, but it's too close. We've got to do that next. Sorry, we can talk about it next time. Yeah, give me an hour next time.
I've noted that request. Right, okay, so thank you, Margaret. Again, members are asked to note the report for information insurance. Yeah. Okay, and I'm aware of time, David, so you know, I will be moving it along a bit quicker, but if we can now go to optometry, Did you need to introduce it? Oh, okay.
Yeah, thank you. So it's good to put the initial report in for optometry. Currently, hopefully it's clear from the report that our role in HIW is restricted to commission higher qualifications, so postgraduate. We don't have any undergraduate or foundation training that we look after. As such, it's a limited role, but what we will be doing in the next 12 months is starting to have some placements for those postgraduate qualifications as well, in optometry practices. So that's quite a big shift for us in terms of our quality and simply from how we ensure that we look after that program properly. So you have limited scope, I guess, in the report, other than the numbers are bill rates currently, which are good. In terms of the qualifications that we do commission, we have reached a kind of a good level of equity across Wales. We have at least two Glastonbury Health Board now that have or are in the process of being trained in the different qualifications. Those qualifications match well with the new optometry contract, which means that optometrists can deliver more services to patients. And we have been quite successful in recruiting to those qualifications. What's perhaps more of a challenge is that some of the qualifications do require placements, and actually we don't have any jurisdiction on those at the moment, so we can only kind of commission the qualifications themselves. However, as I said, this year we're starting to get into that space because we really should be controlling that as HIW, and that's where our work is beginning to outline the kind of quality framework that we'll be using to monitor those and to ensure that they adhere to our quality standards. Other than that, I'm happy to take questions. I appreciate that, again, as everybody said in this, we are at the very beginning of our journey, and perhaps there's not as much information in this report because of our limited role. But happy to take questions.
Okay, thank you. Jill? Yeah, very quickly, conscious of time, two quick questions now. Thanks, and I understand the journey we're on. The first question I think you've partly answered, which is I'd assumed perhaps that we had a role in placements. So I've written down explain HEIW's role. So really keen to see how that develops. And the second question, I guess, comes back to the impact. Optometrists have taken on an awful lot more, huge amounts, a bit like we talked about independent prescribing. Have we got any idea of the impact? You know, in time, HEIW's question from the Welsh Government is going to be about what did you do with the money? Did it have an impact and all that sort of it? So have we got an idea, I suppose, of what's happened in the secondary care as a result? We just simply
Secondary care is always a challenge, as you know,
yes.
in terms of getting information back on, and all you're doing is reducing the queue, if you like. Where we do have really good data and the effectiveness and impact of commissioning higher qualifications, perhaps was most over the period of COVID, where optometrists with independent prescribers could actually see those patients, and the patients weren't able to go into secondary care, so optometrists are managing those a lot more. Where we don't have further impact information is generally down to the new contract, because in the previous contract, obviously, there was form filling for what they've done with patients, and we've had some beginning of kind of what kind of prescribing they were doing, for example, the independent prescribers, and that's probably the easiest low-hanging fruit to pick to see what impact they had, because you can see what they're prescribing, what they're managing. And so we had some initial data that was saying, yes, it appears that they would be managing patients that would otherwise be seen by GPs or in secondary care. So that was very good data with the new contract and new forms and new development. We're at the earliest stages of that, so that is something that we will be getting with time, but we have limited data at the moment.
Yeah.
But there have been some papers out in scientific literature that have shown from Wales that did show the impact, particularly over the course of COVID. So I can share those with you. That's helpful.
Yeah. Okay, any other points or comments?
It's just a welcome, and I think it's very helpful, information. So I'm just not to here, but struck by the comment about trying to fit commissioning to local needs, and to take that to the level of experience and qualification and development of qualifications to support that. And it's just wanting that they wasn't able to, that's diploma that we weren't able to recruit or actually recruit to, although I've found this if a number of people were willing. So maybe that will come right in the future, but very welcome, thank you.
Thank you, Nick. I know from the comments that you've made in the paper, the long-term members of this committee will know that we started from a dataless trying to get data, and the fact we're moving into that now, we're able to have the questions that we're having to gain assurance of the people that we're training are going to make an impact. So I wouldn't be too disheartened about the fact that it will come. You know, we've had to, I think I said somebody recently, push a tree trunk up a nice mountain. You know, that's what it's been like, sometimes trying to get hold of the data to see the significance of the excellent work that's been going on by the staff here to try and improve the commissioning and the quality outcomes for people at service delivery mode. So thank you for the work you're doing there. Yeah, it is. So members are asked to accept the report as assurance of quality process in the role of commissioning in optometry, and members are asked to request to have been having optometry placements for higher qualifications impact in early 2020. Yeah, okay, thank you. Lisa, over to you.
So I'm not going to sort of actually reiterate what's in the report, because actually the key issues are highlighted on the cover paper. But what I did actually want to do was just draw a few sort of areas to your attention. So one of these issues that you will see is we've now introduced to you some information on work-based learning, and I thought it was really important to bring that to you in order that you start to see where that pipeline work actually happens and is taking place. We will actually obviously be showing the data on it, so that's not available for this report, but it was just introducing you to all actually the work that is currently being done. Actually, the healthcare support worker framework and the apprenticeships. The apprenticeships specifically, so members will have heard me say previously, obviously the long-term plan, the workers plan, was published actually for England, and there was a focus in that plan about apprenticeship development. And I knew as soon as that was coming through, actually, that it would actually cause an increase in awareness in Wales. But obviously, I have reiterated previously that the policy on apprenticeship development in Wales is very different to that what is in England. So in response to that, what we've actually been doing is focusing on understanding actually what the appetite and the need is in Wales. And we will see in that report that we just finished a consultation on that exercise. Quite a complex consultation because you've got a different in understanding. And obviously that will be reported to you as well. Picking up on attrition, I think we've had very helpful conversations as a team actually within HEIW, and we are aware that the chair is actually concerned about the word attrition and what it reflects when we actually do talk about it. But we had a very helpful conversation between the professions, and I think it's actually we are moving into looking at attrition tends to be course leavers and for whatever guise, but then actually there's the interruption of studies, and I think there's helpful examples actually being used by sort of getting medical directorates in terms of actually how that is applied. And I think what we want to do is to have a consistent terminology as to what we're capturing, and that needs to be slightly different. So in other words, what we're probably proposing is that introductory studies is looked at in a different vein and not actually badging it as tuition, because it is a very different arrangement. And last but not least then is in terms of the bursary, obviously we provided an update to you on where we were when this report was produced. But what I can say is we received information this week that the consultation proposed by Welsh Government has been delayed. And therefore it's not going to be achieved until well into next year. So that's been, we've had notification of that. But we did know this. Welcome to my world. Good news, not.
There is a lot of good news in the report.
No, the last bit.
A lot of good news.
But I have to say questions and obviously Martin's here as well.
Okay, so now, comments or questions, please.
Ruth, think.
No, there is. Okay, Ruth, well, yeah, a couple of quick ones. I'm overwhelmed by the good news. Yeah, see? There was certainly a lot of good news. I just wanted to pick up the degree apprenticeships and say it's good to see that referred to in here, and the comment that there is a misunderstanding around Wales is really important one. So I think following some kind of effort to communicate what exactly we are responsible for and can do and are impressed to do will be really helpful. It's just underlining that because people are very enthusiastic about it, but they don't understand the constraints.
Yeah, and there is a department which definitely deals specifically with the apprenticeships, and it's fair to say that there needs to be that communication internally. We are in conversation with them as to what that development is or isn't going to be. But obviously we've also got the development of CETA, and it's about the impact of actually what apprenticeships will be actually going forward there as well. But up to now, Welsh Government have actually focused on what degree apprenticeships are available, and they are quite limited. Hence actually why we wanted to actually produce this consultation, because that was produced as a in response to the National Workforce Implementation Plan on sort of what the appetite was as well. So that's actually where we've got to sort of market together. And there's also the conversation then in terms of registered nurses, band 4 registered nurses, as well as to what we're going to use there as well, because once again, that model is very different in England to what we can introduce in here. So there's a lot of discussion. So I don't think we can a judgment really point to what is the right government policy direction in that, but obviously we can do inform as to what we know about the service. There are a lot of apprenticeships at that lower level. The degree of apprenticeship is actually the biggest challenge we've got.
Thank you. And I think people at large probably generally understand the English model and don't understand that we have got differences and constraints here.
And we've just been to do the projects to explain to her what the differences are as well. So we've noticed that in terms of actually what, how it would impact swing range and boys that you must be caught.
Yeah, lots of good news. So inevitably, there's something that seems a little bit less good. But just on the level 4 healthcare support workers, I note that you say that one health board is already restricting potentially the support workers that can release to financial pressures. And just my thoughts that may be something that is going to get worse and others and disappointing, obviously. Particularly, I know there that the salary the costs for these learners aren't covered. So, are we expecting, given that they're wanting to do second cohorts, what's come up?
I think, Martin will come here, because obviously you've done a lot of work on this, and you've got somebody dedicated looking at these pieces of work. Martin can help.
Yeah, we're working with our health board and we've alleviated some of those concerns, and they are releasing at least another 34 cohorts in March, which is good. We've had really ambitious targets in our commissioning around our new level 4 support worker programme. Previously we commissioned about 100 and we've gone to 500 because of the need and demand. we won't get to the 510 this year, but with the March cohorts, we're hoping to get close to it, which will be a really good first year of our new programs.
Okay, thank you.
Very, very quickly, I think I've asked this before, Martin can probably tell me, we've already seen it, but I'm just thinking of the whole commissioning programme. We've got new board members coming on and an understanding of the need for the whole of Wales in terms of the different professions and the list of what those are in total with how many we are able to train. I'm just wondering, have we had that at all? Because I know I keep asking this question, how can we decide how many and which?
So
in terms,
yeah.
Sorry.
Well, so if you want to go and then Lisa will then.
So I don't think we brought that specifically to this committee. However, that information is generally covered in the education training plan.
Yeah.
Because that's where we capture, so you're right to raise that and the conversation can be happening. So if you remember the process of producing after the education training plan, the needs of the workforce from the health board to teacher and are brought in through their ATPs into actually our discussions about that. There's a lot of work then that goes on actually within the teams actually in here, but there is to how that figures out. And of course, to what we then need to look at is actually the capacity within the system, just delivering. So that is then part of the development of the education and training plan. And I would expect that conversation to come there because that's what we've had to look at is to especially the demands on the service, what is that ability to, but also judging, we also look at it at the tail end as well, is that they put that demand in. Do they then offer the vacancies when those graduates actually qualify as well? So that it is that education training plan that actually promotes those.
Yeah, seeing it in one place. So perhaps
I can take that back and form that through the education training plan. It's not necessarily I think it's a broader board discussion.
Yes. Yes.
Any other comments? Some really positive comments within this, some of the work around Powys and because that's a significant piece of work and I think it's worthy of mentioning. Can you just comment realistically on what you think will be the positives for that and whether that could be adopted in some of the other rural areas?
Yeah, so this was something we were really keen on. It took a little bit of while to get the service and the universities to envisage what it could become. So this is, if you like, taking education to the learners rather than learners going to universities. So what this is doing is enabling people who can't actually, because of life circumstances, part-time jobs in the supermarket or childminding to go into universities to train to become nurses. So we've managed to set up something with colleague Llantrithlo in collaboration with Bangor University and Powys to identify individuals that would benefit from this route that we know couldn't train through any other route that we provide. So that's working there. There's lots of lessons learned from that. And we are taking it into Hywel Dda and Swansea University, who have yet not managed to get a dispersed learning cohort. But we've got meetings set up with Swansea and Hywel Dda. Hywel Dda are really keen to have this there, so it's something we're pursuing.
The reason I'm asking that is I think it's a really brilliant piece of work that you've done and presumably satisfied, well, it would have had to satisfy the regulatory requirements of the 2,300 hours. But in relation to the acute care sector, because Powys is not, it doesn't have acute care, how is that managed? Because I think that would be significant in trying to move that to some of the acute provision services like Swansea and Hywel Dda, ensuring that that actually is going to deliver. Because they might say, well, that's Powys, it's very rural, they don't have acute care. They, they commission care from an Iron Bevan and Cumtack. How do those placements
I think the placements are still broad, it's not, the placements are not entirely into Paris.
But that's significant, yeah.
So in other words, you will still offer placement in the variety of sectors, but I think what we're trying to do is coming back to what we said you highlight to do earlier on is the needs of those rural health boards, like ours are, in those two covers, because that's actually what the rest of those last year, so therefore we've worked with those two particular health boards to say, okay, how can we address some needs? And these are the opportunities that we've created, but the experience of those individuals will still be broader. And therefore, they will actually place to expand on some.
I wonder then, Martin, if we could accentuate that in the paper, and in any other subsequent papers, because that's where the challenge has been historically.
Yeah.
If you're going to train in those areas, you're not going to get the clinical experience, and it relates a little bit to the question asked about medicine in terms of the tertiary centres as opposed to rural communities. You know, so we help to have that accentuate.
And because the whole opportunity roles, particular people currently and they're now studying in Clanshire NI, is that they will actually enter the pre-rep program with next year. And that is your headband.
And the other question I had is does that positively relate to the Welsh language as well? And contributing to what we require as an organisation to do, and if that has positive attributes of the culture of those areas, it would be helpful to have that depicted as well.
We can look into that, yeah.
Just to have a comment on it, because I think it meets another part of the requirement. Thanks.
75% of the students' placements are going to be in Powys, the other 25 are going to be outside, so they can follow that whole student journey and pick up their whole learning outcomes.
So that's the accentuate that a little bit more, so it's not seen as a second-rate type of education, that they're still meeting. I know the regulatory requirements will be there, but actually it's how the other universities and health boards might accept that. So really, really helpful. Thank you. Right, so thanks again to the team for the work there. This paper doesn't really show all the work behind it. There's a huge amount that goes into producing this, so can you make sure that we take that back to the staff involved. Members are asked to note the report is for assurance about the quality of our commissioned education. Okay, thank you. Right, how are people in terms of, are you happy to go on? Do you want to 5 minutes stop or? Yeah, 5 minutes stop, and then Anton, we're going to come back and we'll just take questions off the next part of the paper, because I think you've addressed it in the first part. So the people are aware that when we come back, we picked up a couple of minutes there to allow you to have a break. So it's 5 minutes sufficient. Thank you.
Throwing back my.
So we're back online now, so well, I'm sliding across the table here. So welcome back, thank you very much, and I do think that it's fantastic to have people in the room, because it gives the opportunity, maybe we should put some time in a future committee meeting for that conversation, because it does engage people in some of the very, very important information we have. That's not to say you don't engage routinely, but I could tell by the voices in the room it was hard to bring it back together. So apologies if people have been waiting for us online. Right, so we're moving on to strategic matters and 3.1. And Anton, I'm going to ask you to take questions because you did cover it for the majority of the session. Is there anything particularly you wanted to say before?
Yes, I'll say one thing, and maybe it will avoid more questions, and that is this item 3.1, the targeted visit process for postgraduate medical training, is there to explain what came before in the previous report. This is literally how the targeted process works. Happy to take any questions.
Okay, any questions? Ruth?
Well, it's a good question, but I just found this hugely helpful. I thought it was a really good paper, and to have a case study within it, and just it was also extremely helpful. Thinking back, this process has come quite a long way from this. It's just really good to see, and it's set out in such a structured and constructive way. Very helpful. So it's all positive as far as I'm concerned, and I'm very grateful for it.
Thank you. Thank you. Any other comments? Okay, so thank you, Anton, and you've had some very positive comments in relation to the historical development of this. So I was asked to note the targeted visit process, the function of quality management within medical deanery for assurance. Okay, thank you. And we're moving on now to 3.2, which is over to you then, Lisa.
To listen to the community in for information really more than anything. And we've made reference to this in our support paper as well. But also this is what you provide in the community and update on to what we call the post registration element to online education.
Martin?
Just two recent changes since the paper's been produced. One, we have received the ratification from the Welsh Government around the part-time distance learning. So we've now awarded that contract. So that's gone from amber to green. And in terms of the ultrasound, there was a risk around that with learners. We've now been able to progress that, and we've gone live with the tender. So those two of those gone from amber to green.
Okay, thank you. I know that the paper was reviewed by the project board and the executive team. Yeah. Were there any issues?
There? And in addition to that as well, that you mean that you had interactive one-to-one clinical photography, you would now said we actually have that effective formally as well, which is a really good news because the development of that actually was quite extensive and we're really pleased with it. I mean, it's been really well promoted, just the quality of the production like it. But I think that you were listed there and access it and everything.
Okay. So members are asked to note the report. Okay, thank you. Let's get into the next one myself. So part 4, draft committee self-assessment 23-24, over to David.
Okay, diolch yn fawr iawn David. Felly papur yn gofyn am gymerydwyr ydy hon. Mae'r pwyllgor yn gymeryd â hynna'n asesiad o waith pwyllgor flynyddol mwyn darparu
Sorry, can I just, yeah, I think we're having problems with translation. Yeah. Getting fuzzy.
The wind.
Yeah. No. It's like a rush. That's all we're doing.
I think this isn't what we've got this today.
Pardon?
No, there was a shoot battery, so I'll return this one. Okay, that's fine. My note one for today. So paper seeking approval, we can take a self-assessment of the work of the committee on an annual basis. To provide assurance to the board and that of the work of the committee. Members will note that the self-assessment paper has been amended slightly this year. And that's to ensure that in regard to the asking the questions of the participants, the approach is taken across all board and the committees. Subject to receipt of approval from the committee, the process that we're going to take is that we will share the questions with all stakeholders over the next month, and then we'll bring back the reports on the results of the self-assessment process at the next meeting of the committee. So to close, we're seeking approval, please, for the self-assessment questionnaire.
Okay. Do you want to say?
It seems very good. Thank you for the amendments.
You're right. Reflecting a request that we received last year.
Yeah, keep that bit. No. Okay, so thank you, Devon. That's the committee members are asked to approve the content of the committee effectiveness review document highlighted in appendix 1. Okay, thank you. Forward work programme, item 4.2, and again, you David as well.
Yes, so thanks, Chair. So again, this is paper seeking approval from members of the committee in accordance with our standing orders. We review our forward work programme on an annual basis. We're just seeking the committee to please consider the forward work programme for next year and to say please.
Okay, so I'll leave it up. Comments, Councillor?
I think Tom Lawson will be pleased if we changed Tom Lawson on the medicine one to meantime.
Okay.
Lisa?
Just a question, notice some of the items identified in the education performance and quality where they're facing capacity obviously nutrition and fitness, they actually form a component of duty quality paper, and I feel as if it doesn't need to be optimised separately because we would factor that in to appropriate time scheme there. And I just wanted to check actually on the duty quality and the reports which is right. I thought that would already go to the board. It doesn't be security because it might be just this for that meeting.
No, with regards to, so we have shared the forward work programme with the class, so welcome the comments. And so with regards to the first point, as we move on and that. And with regard to the annual quality process, it's a legal requirement right across the board, so we change our things like legislation.
Okay. Conscious might be giving Nick more work here, but optometry is down to be every other business meeting. Is that what you want?
So that reflects the view that's expressed by the committee, but so just checking.
I think in terms of continuing what you've just said, you want to include in further information, getting nods from the independent members at the meeting.
Sorry.
I'm just going to ask, I know I'm currently the chair, but vice chair's here. Are you content? Is there anything in particular, Donna, you would want to comment on? Okay, so item 4.2, members are asked to approve the 2024-25 Education Commissioning Policy Committee for work programme, again highlighted at appendix 1. Yeah. you. So moving on to part 5 for information and noting, I'm required to chair this committee to give an update of the stakeholder reference group meeting verbally, which took place on the 23rd of November. And just to say that I don't give an update on the whole of the stakeholder reference group, only the elements that pertain to the work load of this committee, because the board gets the stakeholder reference group update from the chair of the board, who's also chair of the committee, but as vice chair of the stakeholder reference group, the chair of this committee is the vice chair. So just to say that it was a very, very well attended meeting. It is held online. The CEO did give an update and did comment quite a lot on the strategic workforce implementation, the retention and nurse retention programme, which again significantly affects our commissioning numbers and process. So the fact that update and sought comments from the stakeholder reference group, there's wide consultation on these programmes anyway, and there weren't any questions actually raised of the chief exec from any member of the stakeholder reference group. So I took that as positive that the consultations have actually answered quite a number of the questions. The outline, and it was just significant when I heard from the CEO talk about the numbers of programmes that were put together by HIW. The mental health, which gave an update of 1 year on with regards to the workforce plan, and again significant given the pressures that the mental health processes are under within delivering services within our communities in Wales. And as it's joined with Social Care Wales, the regular meetings that the board has. So again, there was no negative or suggested changes to that. The pharmacy plan, she did comment, and there were comments that might have to be scaled back a little. This was a public meeting, and as yet we don't know what those scalings will be. But I think that's significant in determining what we've just discussed in our meeting about the impact of prescribing and the ongoing transition of our clients in Wales or patients in Wales seeking to access pharmacy services, and what that means is important to maintain the workforce. The primary care plan, the nursing workforce plan, maternity workforce plan, diagnostic and regional working, and she also mentioned the genomics initial workshop and the digital and data strategy. So when you put all that together in the strategic reference group, there's a huge amount of bringing together cross-fertilization in order to deliver on our workforce plan. And she also identified the education and training plan. She did ask for questions. There weren't anything that came forward. The other part of the committee also she gave there was an IMTP update from the Director of Finance, and significant again was the potential challenges of the financial environment that the Welsh Government is currently under, and how that might affect future commission. But significantly in the papers that we've received today and of the commissioning figures, there has been a substantial increase in commissioning. If you look at the trend analysis on the bar chart that we were given across all professions, one of the areas of concern was the potential to reduce GP trainees, and again, I know there was significant discussion at the board around that, trying to steer away from that. GPs are the access point to many of our, and I know we all know that, but important for us to keep an eye on that in terms of quality, because that also affects the multidisciplinary team working in primary care, so they can be mention of that. And then of course there's we've heard about pipelines used in many of the committees. That was discussed under the careers strategy, which Angie Oliver gave an update from the workforce and organisation department. And some of the key business areas was the strategic context in which we're seeking to work to provide services and educate people coming into the service. We've got an ageing membership within Wales. Quite a large number of people are exceeding the ages of 70 plus, and yet the birth rate is reducing. So significantly, how we're going to perpetuate the need for people to come into the NHS. So there was a lot of work's being done on research and horizon scanning and the workforce challenging. But also looking at the careers landscape, what does it mean for people to come into the NHS and a competing set of workforce calls into other areas, such as not just health and social care, but actually pricing of what it means to work in the NHS and what you can gain outside. And I know we've seen today in the dental paper that you can earn more and have a better quality of life, presumably, is what has been said from some people working in private practice, but we've still got to look at the workforce challenges. So again, the careers strategy, which identified 350 plus careers within the NHS, is significant in some of the work that we do, and trying to look at the skills escalator, but also the trajectory for people coming into the NHS, that as you get more mature and older in your occupation, there may be opportunities for you to do other jobs in the National Health Service, so you maintain your continuity and pension. But actually the work experiences also was an issue of trying to get people in, and we know that that is important to this committee, because we've got to look at commissioning and making sure that working with the universities and the further education establishments, that the NHS is still a career and a place that people want to work. So I thought, again, there were no real challenges offered by the stakeholder reference group, because there has been a work plan put together, and my understanding is that they have done considerable engagement on that to gather evidence, which is where they've got the evidence-based force. I think the committee might want to look at that going future outcomes from that careers piece of work. They're consulting on it again from November to December, and it will go to final shaping and then go to board approval. But it might be useful to see whether we could have access to read that approval at some stage, to see the specific elements of that that are related to the commissioning element. And I think that's it. Is there anything else, Lisa, I've forgotten from that, or from my notes?
I think you covered it. I think probably the variety of workforce plans that are in there would be right to reference the matrix working across. So it's the connectivity that we're trying to make sure that we're not reinventing each workforce plan, something that is resource so we can pull that from elsewhere. And I think the retention program you mentioned in there, so that has been launched and it's been really well received by the health boards, and the welcomed in terms of not only as a resource but an opportunity to enhance retention across the whole of the workforce, not just in nursing. But that is that you really moving at pace now. And once again, she's got matrix working across all of our programs, digital internally as well. So it is something to see that, no, it's very good meeting.
Okay. So hopefully people have got the gist of what is independent members will get a full report by the chair of things that pertain to the whole of the organisation, but I've hopefully extrapolated the information that relates to this committee from that. Okay. Right, so it's over to you now, Lisa, again, the care home education facilitators report.
So just to say, this has come into this committee if you've got information. I think it was mentioned in a previous previous book, which we've seen. So this is now part of the National Workforce Implementation Plan delivery, but it was requested by Welsh Government even before then. So the work was commissioned by Welsh Government initially. And obviously that piece of work is now concluded, that has been submitted to Welsh Government and is also reported it was after the evidence requested in the National Workforce Implementation Plan. As you can see, actually from the report, it has been quite successful. The challenges we have now going forward is actually how we integrate this into that multi-professional placement arena. Because obviously that resource is not really seen to be
I'll take the extension.
But I just to say that I was really pleased to see this report here, and I'm really impressed. It's just such an important area, and it's interesting to see the impacts that are recorded in the paper, because they're potentially very positive. So it's the going forward, I think, is the interesting thing. And I don't know what the future chair will think, but I would have thought it might be helpful to bring this back at some point and see where it's got to.
I think it's fair to say, it's about this was a delicate piece of work, yes, and therefore it is now complete and the evidence has been submitted to Welsh Government. We obviously waited to Welsh Government to decide as to how they wanted to progress this, but nevertheless, we're quite grateful that you get a lot of valuable information that you in this particular report, and we're not actually sort of sharing it as such. I think it's actually the dedicated resource actually in 3 care home facilities as well, that will also come to an end as well. But we're already discussing in relation to what GI and TPs going forward as to how this, it might not be dedicated to certain care sectors, because we recognise we've got a primary programme of work nationally. There's a lot of work that is going in terms of community development, community placements, but there's also actually integrating the other professionals as well. So that's a piece of work that we're looking at in terms of helping to take elements of this work going forward, because a care home placement is very very important for your generalist nurses, actually, and others as well. So it is actually drawing that into that arena. And so I don't think it's work with loss, because of the connections and the opportunities I'm seeing, and of course actually the result of that. We've actually enabled actually more nurses within the care home to be identified as what their professional development is about. Because this particular report is part of the plan as well, but not dedicated in this specific way.
And I think that's very encouraging. I think I wasn't envisaging that this would go forward as necessarily something of a package. And it depends very much clearly on what Welsh Government say, but the elements that are built into this in various ways that seem to me to be very positive, and may, I hopefully find some way to be built on and taken forward.
Well, these are the discussions we're having now in terms of next year's activity.
Yeah.
Just a few very quick ones, Chair. I've again really welcomed seeing this come forward. I was surprised that there was, in the list of people that have contributed, there doesn't seem to be local authorities, even though it says in the report about local authorities that they were in the list. So there's a couple of more questions. Is it on Careersville as something that is an option for career?
I think it is, isn't it? Because it's in the nursing building.
Okay, fantastic. Incentives for taking placements. I just wondered what was in it for the care homes. Are the placements built into the nursing courses? And I guess the exit strategy, which Bruce we talked about, or the going forward, whichever way this comes out. But it started me thinking about placements, and I'm sorry, this is slightly off the point check. Do we have a placement map in terms of what we pay, where they are, the different? I know we had something some time ago with different rates, but it started me thinking about. I like to put together a chair to see things in a sort of diagram or whatever of where our placements are.
Is that if you can remember, you've asked that during a previous meeting?
Yes, I know. I'm sorry, I'm guilty of being very
because I was taking it away to see what was the timescale that we could produce that report, because we are looking at that placement opportunity, so working with the digital team to start mapping that out. Then once again, it's not just nurses, it's HPs, the medics, the pharmacists.
I know,
and
the I'm quite interested in as well.
So the care sector is quite a challenge, because if you look at the number of care homes that we've got in here and the number who are not involved in care, so that's actually the biggest challenge. So coming back to one of your questions was about, are these now integrated into our placement, framework architecture? Yes, we want to continue these and enable it to be available to not just practice nurses or primary placements and others as well. We're actually developing placements in many different arenas. When it comes to incentives, I don't think the care homes are paid.
That was always, when I sat on the other side, it's the local authorities, but maybe the health boards, let's be clear, they're not paid actually to have a place. I think that's a disagreement. And I certainly like to see the rest in terms of.
Yeah, so we don't pay for placements as such, but what we do across nursing, and we started doing it now on midwifery, allied health professionals and healthcare sciences, we have a network of practice education facilitators, which we found that are embedded in the health boards that support not only the students on placement, but they support the practice assessors and practice supervisors working with those students as well. So we have about 60, I think, of these staff that, although they're employed by the health boards, we have a leadership role over them, and we manage that network and the quality of that delivery.
And that's great, there's the time, isn't it?
It's time,
The time set aside for supervision.
Absolutely.
You don't think for me is a key issue going forward.
And the conversation we're having is that it's recognise that practice education, business education and facilitation role is so key to the understanding of all our frameworks, really. And I think actually we're moving into that arena where we just had chefs, but you just had sort of, we've got into the primary care. We need to cross this realm, and that's the direction we need to look at it. Rather than go down uni elements, they need to be collectively available to all our students. And that's a work which together. Sorry to repeat. That's all right. Martin.
Just on one of Joe's other points around sort of benefits and impact. Tom made the point earlier on around placements in community for medical students. It's not just about opening up the placement opportunities that we're doing, it's about the length of time the students can go there and acquire more learning outcomes, and that creates really good opportunities for them when they graduate, because they'll see it's a good place to learn and develop their careers. And a byproduct that we're starting to actually see is that by embedding that placement quality infrastructure in nursing homes, it's sufficient as well for OTs and physios and other students. So it really helps with the enablement agenda. So we're starting to see that wider.
I'm positive too, because you have the three arms of tech to work with that ones as well.
Okay, thanks, Donna.
Yeah, just really a comment on what else but to say, I really enjoyed reading this paper. It's a jolly good read, isn't it? Yeah, which was fantastic, actually, and also particularly going out the student reflections of their placements and the experience they've had, and really wanting to see that, whether it's through careers or whether pushed and promoted, because I can imagine this is just a thought from me, but maybe that isn't universally acknowledged, that you can get so much from a placement in a care home. So yeah, that's excellent. This work,
Excellent.
I just can't help myself. I just wanted to say, seeing research and evaluation, especially service evaluation, where we've invested in things in that team, it's great. It's a great paper. I can share it with others.
Yeah. I echo that in relation to these things. Maybe we should be looking a little bit more at the evaluation and the roles the postdocs maybe working within the organisation to look at the impact this committee had on the commissioning. And a couple of questions I have, Martin, in relation to Lisa, in relation to the paper. The Social Care Care Inspectorate Wales and Social Care Wales have now registered all care workers, and I just wondered whether there is some mileage in a combined approach to this, looking at the education and training of people who are responsible for education and training, those types of workers within care homes. And also, in relation to year 3 and the management module of nursing, which is a requirement, are the placements enabling that process as well, where they do the 3 months placement within a care home?
Yeah.
Because that links to leadership, because that significantly impacts on uptake, but also on other learning agendas. And I just wondered whether,
And that's an area we've been discussing later, because we want to do that actually for general practice, so that it equips them to be able to go back into general practice. When we first wanted to do there, we have got this, which is a resource of care looking at us, that's missing things, and that's yours in technically the rest of it. That's been led by Welsh Government, and we've got that meeting. But we actually want to do it in an integrated way, so we don't sign up and not them, but you've got to pull them into that primary community care arena. That is the then because the interface between nurses, community nurses, general practice with that care home section is so fundamentally important, as well as actually the sector, of course. That's where we can deepen and to develop these people so that they provide that network to each other in that community arena.
and the other question I was going to ask was in relation to occupational therapists and physios in terms of the management of care homes. So is there liaison between Care Inspectorate Wales and the responsible individual or the registered manager also being included in this, so it's not, potentially going forward, so you get the placement and the education of a variety of people at that level, which then helps obviously the primary care agenda.
Really discussion actually. Sort of areas about the opportunities you mentioned of the occupational therapists. So that is an area we're looking into as to how we can enhance such employee in that arena. But actually more importantly, we're also discussing with them how they inform the admissions rate going forward. There's no debate about their needs. But actually how they can work with us to actually be able to achieve placements in the broader arena. To realize and somebody to go back as well.
Yeah, so the fact that you had government representatives on this, I think the broader context of the recommendations of this project, it would be need to maybe have researched the element and identify the potential expansion of such a project and the impact that might have had. And so thank you for that, because it was very uplifting to read, because the 25% of people on the register are actually in these homes, and 1 in 5 are now internationally recruited. So the issue around that is the significant career profiling for a number of people that we're training, and that affects people staying and retaining Wales and helping the agenda.
Registered nurses in care homes is a component of the nursing. So we have a dedicated group which is the community nursing workforce plan and inform that as well.
Thank you. So thanks for answering the questions. It was such a good paper, you can tell. It's raised so many questions from around. Brilliant. So thank you. So members are asked to note the report. Yeah. Yeah. Brilliant. Thank you very, very much. Okay, so right. It's now down to me to say, is there any other business not been made aware of any of these? No. Okay, so oh sorry, take your part.
This is an meeting, I can't really, please we put on the record how grateful we are for your chairmanship. You've been a fabulous chairman of the board and got us through good times and bad times. We're all smiling, so thank you so much.
I paid you well, just embarrassing me now. I really wipe that off the minute.
No, I think we would like it to go on the
yeah. Thank you. Thank you, Ruth. Yeah, you are embarrassing. She used to be the CMO when I worked in the Welsh Government. She married then. No, thank you, Ruth. Thanks. Can I just say a huge thanks to everybody. The quality of paper is coming through from when we first started to now, and we have been asked by the chair to do some reflections. It's down to the work that everybody around this table has been leading, because you wouldn't get the quality of papers if you weren't leading the work that underpins the things that you're telling us about. So, and I hope that you find that the challenge is supportive and constructive, and that at the end of the day, the role of this committee is the education and quality. And so we have meaningful education training to prepare the workforce for the future of the NHS. So can I say a huge thank you to everybody involved for the support you've given the independent members, and both myself as chair and vice chairs remains at front for her, and the new vice chairs coming in, but thank you. And the date and time of the next meeting is the 14th of March, the time will be shared.
Confirmed.
Yeah, thank you. So thanks very much, and thank you to everybody online for staying with us, and apologies that we've gone 3 minutes over. Thank you.